Thank you, Dr. Zia, for that wonderful introduction. हमारा आज का session, what we're trying to achieve today is to get a basic knowledge of what the pentacam can offer, what corneal topography can offer in terms of refractive surgery. We've got some esteemed guests here, so it's kind of a little bit nerve-wracking presenting in front of them, but I'll do my best and try to acquaint everyone with what we can extract out of a pentacam. So I don't have any financial disclosures, and so this is a topography just to get you oriented with the maps of the pentacam. So if you can see this is the 4-map refractive map, which is giving you anterior, posterior elevations, the sagittal curvature, and the corneal thickness. A lot of the times, I'm just trying to get you acquainted with most of these maps, just to show you when people see this sagittal curvature map, people start immediately assuming that this is either a pellucid marginal degeneration, and they immediately go to that thought. But we always have to understand that anything with the PMD is actually outside of the 9mm map, and the typical pentacam image is a 9mm map. So you have to think of other things as well, just not, and you cannot diagnose a PMD case, a pellucid marginal degeneration case, or any peripheral degeneration case just on these maps alone. So what should be on your mind when you see something like this? It should be something like keratoconus as well, PMD, Terrien's, macular dystrophy, or just someone who hasn't focused on the image very well, focused on the pentacam and has moved his eyes. So it's always very useful to go back and see the raw images. So what are the raw images for the pentacam? Is these Scheimpflug images, and see if the segmentation was done properly, if there is anything else that you missed at the back. If the segment, all of these maps that you see on the pentacam are always based on the raw images and the segmentation that you see here. If these segmentations are not properly done, then all of your maps are going to be skewed, as you will see later in the presentation. So then we look at something called K readings. Now, what do K readings tell us? Now, remember, K readings, whether they're on the autograph, whether they're on the pentacam, whether they're off of an OCT, they're very limited in the sense they only give you information of the anterior surface, and they only give you information about a certain diameter around the center of the cornea. So about 3.5 millimeters, 4.5 millimeters, that's all it's telling you. So I've seen many cases being referred, and they have K readings that are either high or somewhere, and they've been diagnosed as keratoconus. You do the pentacam, they're not actually keratoconus. So the K readings are not diagnostic, they're just a screening tool. And if you see, there's a huge distribution, we did this at our own center, and there's a huge distribution of K readings, and we always look. So there's always this one variable that keeps coming up with pentacams. It's the Kmax, and if the Kmax is high, then this is a keratoconus. And you'll see in the next few slides, Kmax is not the. It is a good tool in terms of someone who's 2 or 3 standard deviations beyond the normal, but a high Kmax can still be a normal keratoconus case. So again, refractive screen. I went through the segmentation check. Okay, so if you see this case in segmentation, you can see that the green line is the posterior surface of the cornea. It's what the machine thinks is the posterior surface of the cornea, and the red line is what the machine thinks is the anterior surface of the cornea. Now, if you look at this particular image, you can see that the anterior surface of the cornea was imaged very well, but the posterior surface of the cornea is imaged very poorly. So look at the arrow, and it's extremely poorly imaged. And this was actually referred to me by someone, and he said that I'm very confused as to what this is actually. So this is what the image looked like when you do the refractive screen. You can see the anterior surface of the cornea is normal, but the posterior surface of the cornea, it's got the pachymetry wrong, it's got the posterior elevations wrong. And why did that happen? This was actually a case of band keratopathy. You'll see this later. So the band keratopathy created an opacity. That opacity causes a problem with the imaging of the pentacam, and that causes issues. Then again, we keep seeing this as an old sort of topography bystander. We saw that we keep seeing sagittal curvature maps. Now, what are sagittal curvature maps? We have to understand that. Sagittal curvature maps basically assume that it's a Gullstrand reduced eye, which means that the line of sight, center of the pupil, apex, and measurement axis are all equal. And what it does is that it takes the radii of curvature from the center of a cornea, assuming from the center of the cornea to this to the radius in the center. So if I can get a marker here. So if you see this, it's taking the radii of the curvature from the apex to the center of that particular mark at the cornea, assuming that the cornea is spherical. Now, as you can imagine, the cornea is not spherical. So if there ever is alignment issues, it's going to cause huge problems, as you will see in the next few slides. Again, the concept of angle kappa is very important, where there's a difference in the visual axis and the pupillary axis, and I'll explain that as we go along. Now, I'm not going to go too deeply into the types of curvature maps because most of these can be normal even though you have skewed radial axis or whatever, but there's a round and oval which comes in very small astigmative patterns. There's a symmetric bow tie in astigmatism, superior steepening, inferior steepening, asymmetric bow tie with inferior steepening. Now, all of these can be normal. Just because you see this on a sagittal curvature map does not mean that this is a keratoconus cornea. Even if you see skewed radial axis, does not mean that this is a keratoconus cornea. You have to look at the other parameters and then decide for yourself. And then there's these unclassified data. So again, going back to the sagittal curvature map that I alluded to right at the start, if you see something like this, a lot of people have the assumption that this is keratoconus. You're seeing inferior steepening with an asymmetric bow tie. What should be on your mind right when you see this? You should be thinking that is there either a misalignment, meaning the patient was not looking at the center dot that you show him in the pentacam, or there's a high angle kappa. So if you can see, if this person starts looking superiorly and he's actually got a symmetrical bow tie, he will start getting superior steepening. If he's looked down, he'll get inferior steepening or look diagonally, so and so forth and so forth. So you can't be sure just on the sagittal curvature maps. So this is a case that's practically was referred to me as a keratoconus case. So you can see inferior steepening, but if you see at the anterior and posterior elevations, they look normal. We re-imaged this person. Now you can see the posterior elevations went a little bit higher, but the sagittal curvature map became absolutely normal. The anterior elevations became normal, and the posterior elevation slightly higher, but you have to look at the other maps to see if that is abnormal. Then to understand elevation maps, you have to understand that these are not raw data. So if you look at raw elevation data, your normal to mild to advanced keratoconus is not actually that different. So what do? We've borrowed something from geography and we create a reference surface. So those reference surfaces that we've heard of, best fit sphere, best fit ellipsoid, best toric ellipsoid. What does that mean? Best fit sphere has 1 radii of curvature, ellipsoid has 2, and then toric ellipsoid has 3. So all of these are mapped so that you can get your elevation data gets enhanced so you can pick up the cone of the keratoconus. So just as an example, I personally use best fit sphere. So what happens is if you've got a city like this and you've got these buildings, but you've got this one building that goes very high, what will the reference surface will come as an average to all of this, right? But then another enhancement in the pentacam or many machines now is that so a lot of the keratoconuses are now hidden because that one outlier data is actually pulling your best fit sphere higher, and that's why it cannot because it's pulling it higher, the cone becomes hidden. So what then Bellin and Ambrosio did was they created something called the enhanced best fit sphere. So within the center 3 millimeters, they take the data away and they extract it from the peripheral data to see where the best fit sphere was supposed to be. So what that ends up doing is it basically settles down and you taking that outlier data away where the cone is, and you basically put the best fit sphere down, and now the reference to the best fit sphere actually enhances itself, and that causes an exaggeration of the cone. And I'll show you practical data to show you how that differs. Now, if you see the map as a map of a normal astigmatism versus the map of a keratoconus. So in the sagittal curvature, you've got a steep axis and the flat axis. Now remember, the sagittal curvature or tangential curvature, whatever curvature you're talking about, is actually just a derivation off of the elevation data. So if you see, this blue areas would be the steep axis and the red areas would be the flat axis. in terms of the elevation and if you convert it to sagittal curvature. Now, when you look at the elevation data for a keratoconus person, the steep and flat axis don't matter. You're actually seeing a center exaggeration of the thinnest point. That is the keratoconus cone that you're seeing. And if you actually map this out in OCT, you can see that the cornea is actually becoming asymmetric, and you can see that it's drooping downwards to the inferior temporal, usually to the inferior temporal. Again, the concept of that reference surface, if you see a normal best fit sphere, it's going to look like what this is. Then the keratoconic cornea, and if it's a normal best fit sphere, it's going to go a little bit higher, and the cone will become hidden inside that best fit sphere. But then when you do that extrapolation data of the enhanced best fit sphere, the cone will exaggerate itself. And then again, the practical data that I was talking about, the standard best fit sphere, this you can see at the second page of the Pentacam. I use Pentacam, so most of my stuff is going to be on that. So the standard Pentacam image, you see that there's actually very little exaggeration. You can't see the cone, and then when you enhance it, you can see that the elevation data absolutely changes, and then you've got an exaggeration of the cone, and this might be a keratoconus cone. These values you can memorize if you want, and a lot of people have done them, but these values don't mean much to me unless that they're very high. These values don't mean much to, if you're looking at it as a perspective of refractive surgery. It's actually the maps that I'm looking at, and the maps and the elevation data, and then the posterior progression that we'll talk about in the next few slides. Okay, so again, elevation maps have different ways that they can go around, and a lot of these just mean that they have astigmatism. It's not necessary that these are abnormal or normal. Then the tongue and skewed shape it basically relates to the skewed radial axis of the sagittal curvature, but again, doesn't have to be normal. It could be abnormal. Sorry, it could be a large angle kappa. It could be misalignment. And I know I'm going very fast because there's a lot of slides to get through, but just trying to get through the session as much as possible, and then we'll take the questions at the end if there are any. Then you have elevation map. Again, you must be able to identify the cone in most cases. Some cases then you get progression involvement in like very early keratoconus cases. So it's not always that you have to identify the cone, but most of the time if it's a frank keratoconus, you will be able to see the cone on the posterior and anterior curvature elevation. And then if that elevation data is out of range, and it should be at the thinnest location, nowhere else, it should be at the thinnest location. We went through this, and then remember, keratoconus starts at the posterior surface. So again, we're talking about K readings, we're talking about anterior elevation. Remember, keratoconus starts at the posterior surface. So if you have K readings that are normal, it does not mean that you don't have a keratoconus cornea. It just means that the anterior surface is normal, so that the cone hasn't gotten to the anterior surface. But when you do a pentacam, you can get, or any topography, you can get posterior elevation, you can get progression that's out, and that would still mean that there's a biomechanical deficit in that particular person. And then, of course, you have pachymetry, where again, you need a good data in terms of what we've seen in the Scheimpflug images. You need good data in the posterior and anterior surface to have very good pachymetry data, and to see not only that the pachymetry is okay, but the distribution. So there's a shift in the thinnest point, usually inferior temporally. If that happens, then you're thinking more towards keratoconus. But remember, pachymetry can shift a lot of places. It doesn't have to be inferior temporal, and even if it's shifted somewhere else, you have to think of other diagnoses as well outside of keratoconus. So normal pachymetry, you've got this concentric pattern that I've already showed you, where you've got a center of the thinnest point, and then thinner, then it gets thicker around the periphery. Then you've got a horizontal displacement. Now, even though there's a horizontal displacement, it's rarely an ectatic cornea. Horizontal displacement usually means there's either a misalignment or there's a large angle kappa. Rarely it's an ectatic cornea. And then usually you've got that vertical displacement for someone who's ectatic, or a constant rubbing of the eye that's actually affecting the biomechanics of the cornea. Then you've got the bell-shaped, is usually a hallmark of pellucid marginal degeneration. But in my experience, every time you get something like a bell-shaped cornea, or any time you get abnormal pachymetries like this, always go back and check the segmentation. A lot of the time, it's just a segmentation problem. It's not actually diseased cornea. But always, if you want to see PMD, I would advise always to go back and see the shine plug images. Okay, so this is just an example of a low K reading cornea. So you got K readings of 44 and 45, but then he's got, and then we would classify this as a normal case if you're just looking at K readings. But then if you look at the thinnest point, you've got displacement, and then you've got posterior elevation and anterior elevation. So it would be something that this is a cornea that I would image further with epithelial maps, with Corvus. I wouldn't classify it. Now, even though the sagittal curvature is normal, I would still not classify this as a normal case. It was just an example as to what happens. Then you've got another case where you've got K readings of 46 and 50, very high astigmatism, but then and then you look at the sagittal curvature, and a lot of people are going to classify this as abnormal. But then when you look at the anterior elevation maps, you see the posterior elevation maps, you've got the concentric pattern of pachymetry. This person looks absolutely normal if you look at the other maps. So it's not always dependent on the K readings. That's the take-home message that I'm giving you. And if you look at the Bellin embryosal display, which we'll go over in the next couple of things, he's got completely normal corneas, and I haven't showed the second eye, but he's also got symmetric corneas. So this was an absolutely normal case, even though it's a high K readings. Again, the elevation difference. So then what the pentagram gives you is, in that D, the bad D that it gives you, one of the parameters is the difference in elevation. So that difference in elevation is the normal best sphere minus the enhanced best sphere. And then it gives you this data of 5 to 7, and greater than 7 is 2 standard deviations, and you're usually going into an abnormal cornea. But again, I'm saying abnormal cornea. Abnormal cornea doesn't mean keratoconus. A lot of the times this redness can occur because of epithelial hypertrophy. Sometimes it can occur because of contact lens use. So always taking these patients, if you're not sure they're keratoconus, you have to go and look at epithelial data, and if that epithelial data is showing you donut pattern, then you're sure that this is keratoconus. But if it's showing you anything else, an epithelial hypertrophy or something like that, then you're thinking dry eyes and other parameters like that. Then the same thing you're seeing at the posterior surface, the same difference. And then you've got something of the thickness progression that you're seeing. So the thickness progression starts off at the thinnest point and then goes towards the periphery, and it gives you a progression of that thickness, right? The morphology of this thickness profile is a strong predictor of an ectatic cornea or someone who's has biomechanical problems. And then the other thing that you want to see here is the average progression. So this guy has 1.07 average progression. Anytime it's above 1.2, you're going to be thinking that perhaps this is keratoconus. So that average progression index is very important. So just quickly going through the types of curves that you can see. So within the first 6 millimeters, if you've got a sloping curve, this is known as a quick sloping curve. Now there's two types of slopes that you're seeing. One is the corneal spatial thickness profile, which is just based on the thickness. And then one is the percentage thickness. So it's the percentage change. Either of these can be abnormal. And if there's a quick sloping curve, then you want to image further and evaluate if the case is actually ectatic or not. Then you've got an S-shaped curve where you're going to get a quick slope and then it sort of comes back. This is highly predictive of keratoconus. But if you've got an S-shaped curve, your average can actually be normal. So you have to be sure that if your average is normal, but it is an S-shaped curve, again, you have to start looking at either biomechanical data or epithelial data to make sure that this patient is okay if you're going for refractive surgery. And then you've got flat curves. That's more of a Fuchs endothelial dystrophy or bullous keratopathy or even corneal guttatas. And then you've got an inverted curve, and this is usually in some cases of pellucid marginal degeneration. Now, what does the Bellin, the bad D that we keep talking about, what does the bad D actually represent? So these are standard deviation data. So you've got difference in front elevation, difference in back elevation, progression index, thinnest point, and the thinnest point displacement. Now, all of these are standard deviations away from the normal. Now, if the standard, none of these are predictor, any of these are predictors of ectasia. None of these can tell you if this is a keratoconus or not. The only value that has any predictive value is the final D. And if that final D is less than 1.6, we consider it normal. If it's yellow, it's 1.6 to 2.6, and then above 2.6 is red. Usually, if it's a red, it's an abnormal cornea, not necessarily keratoconus. It could be imaging problems. It could be other cases, but it's usually an abnormal cornea or an imaging problem. Yellow is something you have to image more unless you're absolutely sure it's keratoconus or something that you've seen. So just briefly, we'll go through some of the cases, and then we'll wrap the presentation up. So this is a case, if you're undergoing, so let's see this from a perspective of refractive surgery. If this person has a K reading of about 44, 45, you can see anterior elevation data is it's tongue-shaped, posterior elevation is tongue-shaped, but there's a concentric pattern of pachymetry. If you go to the next slide and you see the Bellin Embryoso display, there's no enhancement of the elevation data. The progression curves are normal, and the final D is actually fine. So this is a normal cornea. Then we go to another case. This person has again 44, 45-ish K readings, and then this is just to highlight another modality that we use at the center. You can see the K readings are fine. He's got a little bit of displacement. He's got slightly higher side posterior elevation data. If you go to the next slide, you can see that the bad Ds in both of these are in the yellow range. They've got elevation of the front elevation data. There's no exaggeration of the posterior elevation data, but in terms of the difference, but there is an exaggeration of the posterior elevation data, and that's correlating with the anterior. So that means that they may have some sort of cone. And then you've got, in the other eye, you're seeing something very similar. So that's why we went for biomechanical assessment of this patient. In terms of biomechanical assessment, all of the parameters came back normal, except TBI is a little bit in the yellow range. So this looks like a normal cornea, even though on the pentacam it looked like a little bit of a question mark case. If this patient had come back to me today, I would have also gotten the epithelium done and seen if the distribution of the epithelium was normal. Then this case that I keep talking about, you've seen the butterfly shape. You see this person has a very high astigmatism. He's got a butterfly shaped cornea. He's got some pachymetry issues, and the elevation that's coming back is actually just astigmatism based. So what is this case? This case, and then you're getting posterior elevations and you're getting all of that stuff. Now, what is this case? This case, you should be thinking about large angle kappas, you should be thinking about keratoconus, you should be thinking about pellucid marginal degeneration. So once you go to the Scheimpflug image, this is why it's very important. You see the segmentation actually ends right where the thinning of the cornea starts. So that's why we have to look at this image. Once we look at this image, either this or an anterior segment OCT, you can see the thinning is there and it's in the inferior region. And we're thinking about, now we're very sure that this is probably a case of pellucid marginal degeneration. And that's why this image is very important. Then the next case that we're seeing, again, looking at it as a perspective of refractive surgery, this person has absolutely normal corneas. Posterior part of the cornea and anterior part of the, and then the Bellin Embryoso display is absolutely normal as well. Now, what we will do now, that is the practice in most centers, is we will say that this person can go for refractive surgery. But the other thing that we have to look for in a refractive surgery case is that does this person have a very healthy ocular surface? If he doesn't have an ocular surface that's healthy, going under refractive surgery is going to lead you into all kinds of problems. And that's something that every refractive surgeon has dealt with. So if you see the next case, this person has a highly reactive epithelium. That means there's something either in his cornea or in his ocular surface in terms of his tear film that's causing this problem. Now, when I asked this patient about all of the dry eye symptoms, and all of them were yes. This is someone who needs to be delayed a couple of months or even a year or so to get his ocular surface in line before you actually go for the surgery. And then I think I'll end on this case, is that this is a very important case in the sense that if you see his sagittal curvatures, they're absolutely normal. His anterior curvature is normal. But if you see his pachymetry data, there's some missing zone here, even though it's not saying anything in the Q value, which is the quality specification value. And then if you see this posterior elevation, it's got problems there as well. And it's in both eyes. Now it's exaggerated the cone. If you see the enhanced specific sphere has exaggerated the cone as well, and the D value has gone abnormal. But this is someone I would highly suggest redoing all of these images, because if you redo these images, it could become that this is normal, because the diameter that it's actually using 7.7 millimeters of a diameter, where it should be using 8 millimeters. So it can be just purely out of a lack of imaging that that it's giving me this information. So I think I'll end on this case. If there's any questions, I would like to address them, and then I'll hand it over to Dr. Mazari. Thank you. So we've gone through a lot of information, so let's consolidate that. Anytime you're looking at, first, before you start off with anything, anytime you're looking at any sort of topography data, you have to see the patient first. There's too many instances where we're just looking at this printout and then we're going and then we're saying this is either abnormal or normal. You cannot interpret this data without actually looking at this map. And the reason is that if you've got opacities in the cornea, if any sort of opacity is going to make this map abnormal, because the imaging will not be proper. That's why you have to look at the patient. Then you're getting these 4 maps. This is the sagittal curvature. So sagittal curvature, as I've alluded to before, is highly dependent on the patient looking at the right place. It's highly dependent on having a normal angle kappa, because if you've got someone who's looking somewhere else or has a high angle kappa, this curvature map is going to be skewed, it's going to be steepened, and it's going to show abnormal. So this is actually the last thing that I personally look at when I'm looking at the pentacam. Then you've got the elevation maps. So you've got an anterior elevation and then a posterior elevation. So when you look at these two data, these are relatively less dependent on a good angle kappa, but these are also dependent on angle kappa. So just because you see a tongue shape with a slightly higher elevation data, it does not mean that this is abnormal. You have to look, you have to see if the cone is being exaggerated both on the enhanced best fit sphere and the normal best fit sphere, and then compare that to the pachymetry. So if you've got, for example, this elevation data, you can go right at the thinnest point. So what is the thinnest point? Depending on the machine that you're using and the settings that you've used, this little circle shows you where the thinnest point is. It actually gives the value of the thinnest point here. And that value is what's important if you're just looking at the data. And then this is the posterior elevation. Now, if you can see, the posterior pole here has a little bit of exaggeration in terms of the cone, and that actually translates a little bit to the anterior surface as well. So now we're thinking that possibly this person may be has some sort of biomechanical problem. But then when you go on to the pachymetry is actually concentric. The center of the thickness is actually right at the center of his line of sight. So then we are now thinking that this is not actually an abnormal cornea, because the pachymetry usually changes. Then you go to the second page of this particular data, and you can see that exaggeration of any sort of cone is not happening. So the images that we saw earlier, where you got normal best fit sphere and then you exclude the first 3.5 and extrapolate from the sides, and then when you've got right into the center, there was no exaggeration as such that this would cause any sort of problem. So, and then you look, so this is, just to go through it, this is normal best fit sphere, then this is the enhanced best fit sphere, and these two maps are basically the first map, the first map minus the second map at particular points, and then it gives you the maps here, and then if it's above 7 micron of a difference in anterior and posterior, it gives you a red zone, which kind of alerts you towards keratoconus. But again, just because sometimes you will get posterior that's normal and an anterior that's in the red zone, that could be because of contact lens wear, that could be because of dry eyes, and that's where you need further imaging to see if this person is actually abnormal or is normal. Yeah, so the reliability that he's talking about is actually given by the quality specification value. So that's the Q value that you see here, the QS here. If it says it's okay, then it's usually okay. But again, QS is not always reliable. So if you've got a very advanced keratoconus, you're going to have a quality specification value that usually is in the abnormal range, because imaging advanced keratoconus case is very, very difficult. So it's not always the quality specification value you're seeing. And sometimes when you have corneal opacities, the quality specification value will come back normal. But when you go back and see the pentacam images and you see the Scheimpflug images, those Scheimpflug images are actually abnormal in the sense that it didn't segment very well, because it didn't know where the posterior surface was, where the anterior surface was. So if that is happening, then that is something that you need to go back and see yourself. So the quality specification value is not necessarily the be all and end all of the, you have to go back and see it yourself. You have to see the patient on the slit lamp and then judge based on what you're seeing.
And if we try to simulate it for residents with the visual field analysis, I think the earliest use of AI in ophthalmology started in perimetry. And if we try to apply those concepts on interpretation of topography reports, so maybe it will make easy for the friends who just want to have a look and interpret, and who don't have the time to spend like iconic figures of Dr. Dua and Dr. Hashmani. So the first thing we see there is false positive, false negative things and fixation losses. And as Dr. Numan pointed out, you see, when there is pathology, the reliability of the visual field report will be poor. Those false negative, positive errors and fixation losses will be more in cases of more the patient have glaucomatous loss, more these criteria will be abnormal. So similarly, we have to keep our eyes open here as well, that we want to see whether the report is reliable or it is just distorting because of the dry eyes. But at the same time, we need to remember that the pathologies like keratoconus are also going to impair the reliability indices. And then, yes, sir.
Thank you very much for that very comprehensive account of corneal topography. I have a question and a comment. In all of this, where is angle kappa data coming through? The actual measurement in the figures that you've mentioned.
Sure.
And
okay, so that's a very good question. It may have removed it. Anyways, so the pentacam doesn't actually give you angle kappa.
yeah, exactly.
But there is extrapolation of that angle kappa in the sense of the horizontal displacement of the pupillary center. But obviously, I would recommend that either looking at angle kappa clinically or using another instrument to measure angle kappa.
Yeah.
Absolutely.
So that's very, and that brings me to my comment which you made on your last case. All of this pentacam, no matter what instrument you use, it is not a substitute for clinical examination. You have to undertake a thorough clinical examination. And if you see Vox striae, you see a Fleischer ring, if you see anterior opacities, no matter what this tells you, this is keratoconus. And don't forget that ectatic disorders start with myopia, high myopic astigmatism, keratoconus, keratoglobus, pellucid, all in the same family. And over time, you can see we have published this combined corneal ectasia. The same eye will show a keratoglobus pattern, but the center will have a cone. And over time, you can see a patient you followed up, the keratoconus will extend all the way to the periphery, become keratoglobus. So they're all a spectrum of disorders. And looking at just one parameter, be it OCT or refraction or pentacam or any other topography machine, itself is not sufficient. Your thorough clinical examination history, it pointed out that contact lens wear, if the patient's wearing contact lenses, has just taken them off yesterday and you've done the topography, you'll get completely wrong readings. And that's not reliable. So all these points have been mentioned, but they've just emphasized that the point that clinical examination and history are absolutely fundamental to any equipment we use in ophthalmology.
Thank you so much for that comment. Just to add on, just 2 days ago, I had my one of the residents at our center come to me, and she's like, I don't understand this topography. Can you explain it to me? And the patient basically had superior steepening, pachymetry was normal, and the posterior elevation data was normal. And she's like, I don't think that this is keratoconus, but the sagittal curvature maps are telling me that this is superior steepening, which is not in keratoconus. That's why she didn't understand it. So I asked her, did you look at the patient? And she said yes. And I asked her, what did you see in the patient? And she's like, I saw nothing. I asked her to go back and look at the patient. Basically, what was there was that there was a subtle opacity right at the superior part of the cornea. That superior opacity had induced a subtle scarring, but because of that superior opacity, the segmentation check was not good, and so you don't have that superior steepening was actually not real. It was a fabrication based on what the pentacam thought it was seeing. So yes, excellent point. Thank you very much, sir.
So, as our seniors have emphasized, the panoramic view of any clinical patient is very important. While we are, again I come to glaucoma, while we are discussing glaucoma, sometimes we are so absorbed in OCT and visual fields that we forget that the clinical documentation of CD ratio, the presence of notch, the presence of family history, how important it is. So I always say that see, the patient is located in a family, and family is located in a society, and the eye is located in the orbit, and orbit is located in the body. So the same thing applies here to the cornea as well. We have to see it, and we have to train ourselves in clinical examinations and in interventions classically as strong as possible. And now we shift kind of little more basic discussion.
One more important point, which is the pentacam is not used only for diagnosing ectasias. The emphasis of this topic today was on ectasias. I use it a lot for deciding which sutures to remove after corneal surgery, like DALC or penetrating keratoplasty. Unlike keratometry, the pentacam works on semi-meridians for astigmatism. And if you look at the refraction, you will find that, okay, we have to remove these two stitches. If you look at the pentacam, it may be this one and this one, not the straight line, because the simulated K readings will be an extrapolation of the data, but it works in semi-meridian. So you might change 1 clock hour of the axis of the stitch you have to remove. But all that is still secondary, because if you do the patient's refraction and the refraction and the pentacam axis coincide, you get the best result of stitch removal. If they don't coincide, you will still go by the pentacam, but you don't get the best result. So there are those subtleties as well. And the other thing I use it for is densitometry. Pentacam has a very good function of densitometry. You can measure corneal density, and in inflammations and infections and response to your treatment, densitometry becomes a very, very quantitative measure of how quickly it is responding. So there are other functions within the pentacam we tend not to use as much as we should.
Question for you. So when you're talking about removing sutures in after keratoplasty, are you looking at the sagittal curvature map? How are you making the decision of where to remove the sutures?
So what we're doing is we're looking at refraction first,
Yeah.
and which axis is telling us, and we're looking at the anterior curvature maps.
Yeah.
Because that's what is being altered by your sutures.
Absolutely.
And then we try to compare the correlation between the two. If the two match, then we will go and remove the two sutures, right? But if they don't match, then the question is, do you go with the topography indicated suture or with the refraction indicated suture? And then we tend to prefer the refraction indicated suture rather than topography. The same, you will see this very often when you're doing laser refractive surgery. The topography does not coincide with the refraction. Then in that situation, we always base our treatment on the refraction,
Refraction, absolutely.
not on the topography, because that represents the whole, not just the cornea. And the same kind of principle applies here. When you're removing the stitch, we would prefer the refraction over the topography if they do not align.
Thank you so much. Absolutely.
Yes, yes. So in IOL calculation, I think it's always important to look at topography because you will miss quite a few things. If you do your normal IOL master and you do your calculation, but if there is irregular astigmatism, if there are subtle changes in the cornea, that will not be picked up in the IOL keratometry. So particularly if you're going for premium IOLs, and if you're going for even toric IOLs, then it's very important that you do check topography and then make a decision, because sometimes the patient may not be suited for. You mentioned about how you should normalize the patient if they've got dry eyes. It may take a few months before you decide on the treatment. But what is important is that you may normalize with vigorous efforts, and after 2 months you do the surgery, but for the rest of the patient's life, he will go back to his old habits. And all the problems will come back. And with that, the exaggerated problems of your intervention. They will not be happy anymore because their dry eye problems, ocular surface problems have come back. So just by making it normal for the purpose of surgery does not always solve the problem. That's why topography again becomes important. So same applies for cataract. If the topography is not right, then you have to warn the patient that maybe not premium IOLs, maybe let's do this as a toric or a monofocal.
I would just like to add to that. It's one of the functions of the pentacam that's not used as often, the IOL calculation part of it, especially in someone who's, as sir mentioned, irregular astigmatism. But then after that, also someone who's post-refractive surgery, especially if you've got like the older IOL masters and the older scans, the topography can give you different types of K readings in terms of true net power and the holiday display and all of that stuff. And it sort of changes the K readings based on what it's calculating. So the sagittal curvature works on a gold strand reduced dye, it works on a keratometric index that was actually calculated for the autorefractometer. Then you've got the EKR values and the holiday formulas that then go into the true K formulas that were developed for refractive surgery cases, which can actually enhance especially your premium IOL cases. That's an excellent point. Thank you.
Don't drop at 0.25 diopter. So you can do very accurate and calculate very precisely. But if the lens you're going to put in has a choice of a 0.5 only difference, then you're no point doing so much sophisticated calculation when you've got only you still have the error of 0.5.
Sir, would you like to add something or say something? Ashmani sir? Galilei bhi hai. Do you use Galilei in your practice? No. तो जो बैड डिस्प्ले है वो बैड नहीं है, वो बहुत अच्छा है असल में. It's not bad actually, it's very good. But it is Berlin Ambrosio display. तो वो भी जो है मैं उसको भी पैटर्न स्टैंडर्ड डेविएशन से थोड़ा सा समझता हूँ कि it compares.
So most of the indices that are in the market are based on the anterior corneal curvature. So they're all looking at either sagittal curvature, elevation data, progression index, but they're not looking at the posterior elevation data. So the BAD D was the first one that looked at posterior elevation data, and that's why it works so well, is because the keratoconic cone actually starts at the posterior site, and that it signifies that you have some biomechanical problem.
तो ये मेनली जो ऑब स्कैन हम बड़े यूज टू हो गए थे उसको देखने में, तो वो और उसका और पेंटाकैम का और गैलीले का फर्क ज़्यादा यही है कि ये पेंटाकैम और गैलीले दे टेक इनटू अकाउंट द पोस्टीरियर कॉर्नियल सरफेस इन डिटेल, जो कि उसमें इतना इफेक्टिवली पॉसिबल नहीं था ऑब स्कैन में. और जैसे नुमान ने बताया कि जो बैड डिस्प्ले है ये बहुत सेंसिटिव है और इसको समझना बहुत ज़रूरी है एक्टेजिया पॉइंट ऑफ व्यू से। इसमें गैलीले जो है वो आपको इंडिसेस देता है, लेकिन उसमें फिर थोड़ा सा आपको खुद माइंड लगाना पड़ता है, और वो जो इंडिसेस गैलीले केराटोकोनस रिपोर्ट में देता है वो थोड़ा सा फ्रेंडली इस लिहाज से तो लगता है कि अगर आपने पेंटाकैम को बहुत स्टडी नहीं किया हुआ तो आप इसको बैड डिस्प्ले को समझ नहीं पाएंगे बर्ड्स आई व्यू से। थोड़ा सा उसकी डिटेल में जाना पड़ेगा कि ये कर्व कैसे डेविएट करती है, और कौन, जैसे नुमान ने बताया क्या थी वो वैल्यू, फाइनल डी।
Finally.
तो फाइनल डी वैल्यू इज वेरी इंपॉर्टेंट। तो बहरहाल ये दोनों मशीन्स दे आर क्वाइट competitive to each other and probably the most widely used machines for topography are Pentacam and Galilei. तो चूंकि थोड़ा सा हमने इस सेशन को रेजिडेंट्स के लिए भी ओरिएंटेट किया हुआ था, तो हमारे एक स्पीकर जो है वो अभी पहुंचने वाले हैं दूसरे हॉल में, वो बिजी थे। तो ये टोपोग्राफी बेसिक्स में अब आप बिल्कुल हम रेजिडेंट लेवल पे देखते हैं कि आपके हाथ में टोपोग्राफी आ गई है तो कैसे आपने उसको इंटरप्रेट करना है। टोपोग्राफी कॉर्नियल मैपिंग है, जैसे हमने पहले डिस्कस कर लिया। टोमोग्राफी और टोपोग्राफी में क्या फर्क है? टोमोग्राफी इज स्टडिंग द क्रॉस सेक्शंस and topography is studying the surface. And Dr. Abdullah Mazri is there. He is resident, second year resident at LRBT Eye Hospital, and he will quickly go through the topography basics.
Assalamu alaikum everyone. So as Dr. Mazri was already discussing the topography versus tomography, what's the difference between them? So when we look at the satellite picture of the earth, so we look at the surface of the earth, somewhere there are mountains, kahin pe pahad hain, kahin pe zameen hai, somewhere there is flat area and somewhere there are oceans. So the surface study is known as topography, whereas if we do a cross section, then we are studying the tomography. So the recent machines, they have both these features. They do topography as well as tomography. So some of the devices used to study the corneal topography are this is the Placido disc. So if we जो इसकी evolution हुई है, if we go in the past, the Placido discs were used, जिसके अंदर ये Myers rings हैं, they are visible, and this is the example of Placido disc. You see on the right side, these are the regular Meyer rings, okay, and and this on the left side, you can see that there is surface irregularity. Yes. So the principles of topography are, as I was already discussing, they could be Placido disc based, and which was used in the past, and then came the orb scan, which used a scanning slit technique, but we'll more emphasize in this presentation on the Schoenfeld principle and Galilei as well as Pentacam. So this is the picture of the Pentacam, and Pentacam uses a principle known as Schoenfeld principle. What we see is usually this is the subject and this is the image. So the image formation is parallel, the line of image formation is parallel to this subject formation. But in this Schoenfeld principle, what we do is, this is the Schoenfeld intersection point, and we know light is, this is the subject, and this is the line of the image, line of the subject, and line of the object. They meet at a point known as Schoenfeld intersection point. So we do multiple scans in this way, and a high resolution image is obtained in this way. So this is the overview of the printout we get in the Pentacam. These are some of the printouts. And first of all, we'll study the refractive maps. So this is the quality scan of this specific pentacam. This can be okay or a data stats and various types. So first of all, we see the quality of the scan like we do in OCT. OCT RNFL and OCT macula, we see the quality of the scan. If the quality is faulty, then we might have to do the scan again. So in this slide, there you see, this is the quality of the scan. Data means that there is some misinterpretation or the data has not been properly documented, so the person doing the scan might have to do it again. And then it comes the Q value. So the Q value is because the shape of the cornea is not like a spherical surface. It's not like like a football. It is flattened while towards the periphery, while in the center it's round. So that's why to study the asphericity of the cornea, we calculate the Q value. If the Q value is in up to minus 0.26, it means that it's the normal value, the normal shape of the cornea is prolate because it's flattened on the side. While if it's oblate, like we'll study further on, and like when we do LASIK of a patient who is a myope, then the cornea, because we ablate the cornea from the center, the cornea will become more prolate. So the minus value will increase. While if we do a LASIK of a hyperopic patient, then we ablate the cornea from the periphery. So the cornea will become oblate and we will have a plus value over here. So this is the example of, this is a spherical surface which has a Q value of 0. This is wrong. Actually, Q value is greater than 0 in case of oblate, and it's less than 0 in prolate lens. So then we are studying the different values on the printout we see. These are the keratometric values. So this is the K1 value, which is usually the flatter meridian is shown as a blue line on the axial curvature map, and the steeper meridian is shown as a red line on the axial curvature map. This is the K1 value. As we already know, there are two keratometric indices, and this is the K mean value of those two keratometric values. This is the K max, because we study whole of the curvature of the cornea, whole of the surface of the cornea. So where there is the maximum keratometric value is known as the K max on the front surface. Likewise, we have the same values for the back surface of the cornea as well. So this is the astigmatism of the front surface of the cornea. And this is the, we'll see a printout later on. This is the pupillary center. A plus sign on the map signifies that it's the center of the pupil, which is the vertex of the pupil actually. And this 0 sign, which is shown as white, is the thinnest part of the cornea. No, this is the apex of the cornea. Sorry, the thinnest part is shown by this black circle. These are some of the other values. The pupillary diameter, 2.74 millimeter. It also measures the pupillary diameter. So some of the maps are, this is the axial or sagittal curvature map. This is the red line we were talking about. This is the steeper meridian, and this is the flatter meridian in this case. And this is the front elevation map. This is the pachymetry map, and this is the back elevation map. So from where I studied the lectures from Professor Mahfouz Hussain. He said the most significant is the posterior elevation map. So we must see the posterior elevation map first if we want to detect early keratoconus. The changes are earliest seen in the posterior elevation maps. So in this presentation we'll discuss it in the sequence. Firstly we'll discuss the anterior sagittal map. It represents the dioptric power of the cornea on various points. And as I've already told, the steep areas are represented in hot colors, while flat areas are represented in cold colors. These cold and hot colors might be different in in Galilei they are coded differently, and in Pentagon they are coded differently. But generally there is this marking scale on the right side. This is a good parameter to know which are the cool colors and which are the hot colors. So in this type, this is the cool color, green, blue, these are cool colors, okay? So when we move upwards from orange to red to purple and dark purple, these are the hot colors. So in this particular axial curvature map, this is the steeper meridian, which is shown by the arrowhead. This is the steeper meridian coded in red color and flatter meridian coded in blue color. These are the various shapes on the axial curvature map. So anyone can tell which shape is this? Anyone? This is the symmetrical vertical bow tie pattern, okay? Because it's shaped like a bow tie and it's symmetrical. The superior and the inferior halves are symmetrical. And these are the various shapes we see on the, axial curvature map. They may be symmetric or asymmetric. There may be inferior steepening or superior steepening and a skewed radial axis. So various types of shapes, symmetric shapes, asymmetric shapes. These have their own significance when we're studying the pathology. One of the example is the butterfly shape pattern, which is seen in the pellucid marginal degeneration. And these are the symmetric shapes. You see round, oval, and symmetric bow tie. Symmetric shapes are relatively less prone to have keratoconus or ectasias, while asymmetric are more prone to have keratoconus or corneal ectasias. In the same way, with the rule astigmatism is relatively safer as compared to against the rule astigmatism. So against the rule is more prone to have those changes. So these are some of the indices quoted here at the bottom. This is the superior inferior asymmetry. So between the superior and inferior half, what's the asymmetry? This is an indices on this pentacam as well as Galileo maps. If there is, inferior steepening like this is an asymmetrical bow tie pattern with inferior steepening. So these are the normal values. Inferior superior asymmetry less than 1.5 is normal, and superior inferior of less than 2.5 is normal. Whereas if we have greater than 1.5 inferior superior asymmetry, then this patient might have corneal ectasia, that is keratoconus. In the same way, in this case, if this patient has an asymmetrical bow tie or inferior steepening, then this value would be enlarged. And in this patient, you see there is superior steepening, and this is also asymmetrical bow tie with superior steepening. So this will have increased SI value, superior to inferior asymmetry. This is skewed radial axis we were talking about. On the steeper meridian of the cornea, we are studying the steeper meridian of the cornea. Sometimes what happens is, there is some angle present in the steeper meridian of the cornea, which is known as skewed radial axis. You see, previously we were studying like this was the pattern, like this or like this, with superior steepening or inferior steepening. But if superiorly the vertical meridian is at an angle to the inferior half with the vertical meridian, this is known as skewed radial axis. So it also has a normal value of lesser than 22 degrees, but if it's more than 22 degrees, then it's also significant. And these are some of the patterns we were talking about. It might be junctional, claw, irregular. These are the high risk parameters. There are many parameters, but some of them are listed over here. And there is controversy. Some say that Kmax of greater than 47.2 is significant, but here it is listed Kmax K of greater than 50, skewed radial axis of greater than 22 degrees. And we always see whole of the map, and we must see the elevation maps first, and followed by the pachymetry map, and followed by the sagittal map in the end, according to my knowledge, what I have studied and what I have listened to the professors. These are the moderate risk ones. This was the high risk, greater than 50. These are the moderate risk, 47, greater than 47.2 K value. And inferior superior, we already discussed superior inferior and inferior superior asymmetry. So if anyone can tell what's this pattern we see over here, any one of you on this sagittal map. This is also a bow tie pattern, but a horizontal bow tie pattern. This is the vertical meridian, this is the horizontal meridian, which is steeper in this case. So this is against the rule astigmatism, with the steeper meridian in the horizontal axis, against the rule astigmatism with the horizontal bow tie, symmetrical horizontal bow tie pattern. And this is the flatter meridian. And this is what we may say oblique astigmatism with the this is the steeper meridian and this is the flatter meridian with a blue line. So this is also a symmetrical pattern, but it's coated, in the hot colors. See here, these are the hot colors: purple, red, orange. It's a symmetrical bow tie, but a hot symmetrical bow tie. So this is how we report this corneal topography maps with the Kmax of around, this is around about 61.7. This is also a hot color. In the center, it's also symmetrical, but there is a cone. There is some ectasia with a hot color, with a purple color in the center at the apex. And we see this pattern. This is, hot area superiorly, like this. And this is inferior steepening with a hot area inferiorly. And these are the cool areas. So anyone can tell this patient might have gone which procedure? Any one of you? If he's gone for LASIK, so which procedure it could be, as I've already told it in the start. This patient might have gone, the K values are reduced. He would be a myope who has gone ablation from the center. So these K values are reduced, they are cool, but the K values are low. So we ablate from the center in case of a, LASIK, doing LASIK for a myope patient. So it shows that he could be a myope with this K values. And usually in myopes, the minimum K value we target for is 33 diopters. And there is also a formula for calculating that K value. So if it comes less than 33 diopters, if we're doing LASIK for a myope patient, then there is a higher risk for corneal ectasia afterwards. So this patient might have undergone for LASIK, femto-LASIK or TPRK for having myopic correction. This is the skewed radial axis. You see, this is the steeper meridian, but this is angled like this. This is the straight line and this is the angle. If this angle is, here is the angle is quoted, okay, it's from 30 to around, 70 degrees. So it's around about like 38 to 40 degrees. If it's more than 22 degrees, that's significant. If skewed radial axis is more than 22 degrees, that's significant. But this patient might have some corneal ectasia, keratoconus. This is inferior steepening with an asymmetrical bow tie pattern. This is a bow tie, but with an inferior steepening and hot area inferiorly more than superiorly. This is, what's this pattern? Anyone? Dr. West? This is a vertical bow tie pattern with superior steepening. Hot area superiorly, yes. This is also hot area inferiorly and inferior steepening with a skewed radial axis of about 25 degrees. You see? So this is what I told you about. This is the butterfly pattern. Butterfly pattern is usually seen in the pellucid marginal degeneration. You see, this is shaped like a butterfly. It has broad wings on the sides, not like a bow tie. A bow tie was relatively oval, but it is broad based. So this patient might have pellucid marginal degeneration. This is also a pattern with inferior steepening and hot area inferiorly, and these are the K values in these areas. Now we come to the elevation maps. The elevation maps are usually studied with the help of a best fit. There are three forms to study these elevation maps. It could be a best fit sphere or a best fit ellipsoid or a best fit toric ellipsoid. So usually what we see on the maps is it's compared to a best fit sphere. So this is the, if this is a spherical surface shaped like this, you see this surface is relatively inferior to this normal surface, which will be seen on the elevation map as compared to a normal best fit sphere. And if it's a minus value, it means that on that point on the posterior elevation map, the cornea is relatively thick. We will discuss that later in the detail. While if it's in the plus form, we can see the cornea of that surface as compared to the best fit sphere is elevated. You see this. So this is a normal cool colors. Okay, these are the minus values, and these are non-significant minus values with the hot island, cool island superiorly and inferiorly. For elevation maps, we use these terms like cool islands, a donut shaped pattern, embryo shaped pattern. These are the cool areas superiorly and inferiorly. This is in minus. We have to understand this because in the previous slide, this minus means that in that area the cornea is in the safe region. It's actually thick in those areas. So minus is safe. Okay. In in this map, these are the islands superiorly and inferiorly. This is also a pattern. Dr. Numan might correct me if I'm interpreting it in. मैंने कहा आप correct कर सकते हैं अगर कहीं पे कोई if I'm committing any mistake. Sure. Yeah, मैं किसी दूसरे हॉल में था. तो ये कुछ पैटर्न्स हैं जो इसके ऊपर हमें नजर आते हैं. ये this is the superior and inferior and cool islands. These are the hot colors. These are some of the shapes shown on these maps. These are superior and inferior islands, and this is the what we call an embryo shape pattern. This is the embryo shape pattern.
That I would like to add on all of this, that I don't go through this in my presentations because I really don't feel that it's that important. This is sort of a leftover from the topography era where we only had the anterior surface, and this was put in a high risk, medium risk, moderate risk. Anytime you see this, yes, it is a risk for a keratoconus, but anytime you see this, you want to go back and again check segmentation, you want to check alignment, see the angle kappa. If those things are normal, then yes, you can think of the axial map as being abnormal. There's another thing that I forgot to mention that you can do if you want to see if this is an alignment issue, just as a very quick thing. There's another map on the pentacam, it's known as the tangential curvatures. So like I mentioned earlier, sagittal curvature actually takes the radii of curvature as one cornea. So it takes on that 2 or 3 points, it makes this cornea spherical. It assumes it's spherical from that 3 points, and then it takes the point from the center of the cornea, right? The radius of that entire cornea. What tangentials does, on the other hand, is it makes very small circles on various different parts of the cornea, and then it takes a radii of curvature from that from those smaller points. So because it's taking so many points, it's actually less prone to decentration because of angle kappa and all of that stuff. So if you're thinking along those lines, you can, it also benefits to go and look at the tangential curvature maps, and that makes it easier. But these things I don't really follow. I look at elevation data first, then the pachymetry data, and then the bad display. This is sort of something that I look at the as a last resort, or if I'm doing some corneal based surgery in terms of intacts or cares or something like that. That's where I use it as more as a refractive tool than a diagnostic modality for keratoconus. Sure.
What, and this is from experience, the figure of the keratometry is, in terms of the development of the eye, is to match the length of the eye. So you will see if the eye is short and you have a greater corneal curvature, the focus is on the retina. And that compensatory mechanism you will see in many eyes. So you have to correlate it with the length of the eye. And if the length of the eye is very long and you have a flatter cornea, that means trying to compensate for that. So in that context, you then interpret whether the risk is high or not. So if the length is normal and then it is 50 or 55, then you know that it's probably abnormally more than what it should be.
And one more comment on, yeah, that's excellent. And we actually did a little bit of data collection on this, and it shows there is always a mild, moderate correlation with the length of the eye and the white to white with flattening. So yes, absolutely, I agree with you. The other thing was you mentioned that the Q, sorry, just give me 1 second. You mentioned that the Q value becomes more towards the positive side after LASIK. So there's two things that we have to realize. There are certain LASIK that were designed for maintaining spherical aberration and maintaining the Q value, like custom Q LASIK. But even then, we see a shift towards positivity, and there's two reasons for that. One of the reasons is that the pentacam or any topography device, our calculations are based on the assumption that the eye is spherical and orthogonal, and that causes so that means that it is actually not designed to look at post-refractive eyes, number one. And number two, because you're flattening the center, the Q value that you see on the pentacam by default is on 9 millimeters, but your ablation zone in LASIK is 6.5 with a transition zone. So our pentacam is not designed to look at post-refractive data, so it will always go into a positive ablation zone. That's just one.
So as we see the biometry, sometimes nature plays amazingly. That this very unusually short or long eye, but the patient is emmetrope, and generally it is compensated by cornea. It may be very high keratometric value, which kept the image on the retina for the whole life of the patient. So this is what the nature is doing, and that's why it's important to keep our eyes open, as our respected Dr. Dua pointed out, that we have to see the whole eye and all the features and the clinical examination, of course. And we are almost to the end of the session now, but I'll just go through few slides to see if I can make some point about Galilei as well. See, this is dual Scheimpflug principle, which was explained by Dr. Noman and Abdullah both, that you tilt the camera in a manner that the intersection point remains same at all the points, and that's what the Scheimpflug principle is, and that's what made it easy to map both anterior and posterior corneal surfaces effectively. And the dual Scheimpflug imaging captures slit images from opposite sides of the illuminated slit, and this allows the assessment of the anterior and posterior corneal topography. So Galilei captures slit images from opposite sides, and this imaging technique improves the detection of the posterior corneal surface. And these things are almost common to pentacam and Galilei, because the pentacam also uses Scheimpflug principle. And the other OPD scan by NIDEC probably has this limitation, and the Placido based scans also have a limitation that they are not able to analyze the posterior corneal surface effectively. And this is the same factor which was already explained, that dual Scheimpflug imaging technique averages the decentration error, and that reduces the risk of error quite markedly. So it is independent of the inclined surfaces, and thus allows accurate pachymetry without the knowledge of the actual decentration of the slit from the image. So these are the optical gimmicks, actually sometimes so difficult to understand that what is actually happening. Even one of the engineers who was visiting from Sifi, Italy to Pakistan, and he was explaining to me the Evolux, their IDO 5UL, and I told him that I have used Lucidis. He said, nobody in the world knows how Lucidis has introduced IDO for near. So this is what the companies tell us. They have some graphics, and then we try to grasp it. But the residents who are good in physics and who have studied their chapters of light in their basic physics education, they are good in optics, and they are able to pick up at least the comparison of the devices and the IOLs. So if you are good in optics, you are good in understanding of the lenses, their behaviors, what is extended depth of focus, what is defocus, what is coma, and what are the skew deviations, and ultimately you should be able to understand what these topographers are doing and what these printouts mean. And if we try to kind of dive into the details and try to understand the basic principles behind these machines which develop them, you start enjoying your work and you start developing love for your specialty and for your subspecialty. So that's why it's important to run these sessions, to interact, to try to understand. It is a simple thing that the visual field comes, dark is absent visual field and white is present visual field. And the more the darker is, the more the impairment is. But that's, very simple thing. If you really know the segments of the visual field, the reliability criterias, the kind of artificial intelligence used. So I feel that in my country at least, our residents and our young consultants need to understand these two topography reports. One is Galilei and one is Pentacam, because of the economic limitations, we cannot meet the ideals every time. So they are similar, except that Noman explained there is a bad display in Pentacam, and all the topographers have 4 maps, as was explained by Dr. Abdullah and Dr. Noman. So with this we come to the end of the session, and if there are any closing remarks by Dr. Dua, we can have it, and then we close the session. Dena mic.
I just want to, just two sentences really. All these machines are based on certain presumptions. They don't tell us what those presumptions are, but they have to use them to make them work. And sometimes they do not give you what is absolutely accurate. And that's where they go wrong. So your clinical experience and your clinical knowledge and the clinical examination is very important to correlate with these things. The second important thing is, whenever you apply all these mathematical principles to a piece of plastic, it works 100% of the time. When you apply it to a living tissue like the eye, which heals back at you, no matter how precise your laser energy is, you are creating a wound, and there's a wound healing response, and that is different from individual to individual. And how much more wound healing occurs will give you the ultimate outcome of your refractive correction. And that might not be what you expect, because your calculations were perfect, but the wound healing was different. And this epithelial thickness can be different, regeneration of the epithelium, filling the gap, etc., etc. So you're dealing with a biological tissue, and mathematical principles do not always apply because of the wound healing response. And there are assumptions within all of this. Those assumptions may not apply to a given patient, and hence it might be wrong in your diagnosis. So keep an open mind. Always correlate clinically.
Stressing the point, always have a panoramic view. Always, yes, family history, clinical examination, all the mentioned tests, always incorporate. It's like working like a secret agent. We are working on the eye. Get all the clues, and then you reach the correct diagnosis, and the correct diagnosis paves the path for the right decision in management. So thank you very much. Let's have a group photo, please.